Okay. Well, thank you so much, Dr. Pennell, for providing such wonderful updated information on what we know about care of women with epilepsy and pregnancy. I have a few questions from the audience. And one of the questions is, what do you say to women who may call you and say, I'm pregnant and I stopped taking my anti-seizure medicines because I'm worried they'll cause problems to the baby?
Yeah, so first of all, right away to take the medications and to, be glad they reached out to us. But yeah, it's particularly risky, and it really brings up the point that this should really be an ongoing conversation and dialogue with our patients long before they say, oh, I'm thinking of getting pregnant. 50% of pregnancies are unplanned, and we also need to have a good contraception option with them, and really a discussion the entire time, and how important it is not to stop the medications. Just to add a little personal note to it, one of the biggest tragedies I ever had is a woman was sent to me in early pregnancy, and I felt I went through every possible reason why she should continue her medications and how the benefit was there. And we got a call about 10 days later that she was found passed away from sudden unexpected death and epilepsy. And so it's a loss of two lives. We tried to find out what was going on. We found out she never went to the pharmacy, picked up her medicines, and it's really tragic. So, a sudden drop in medications is just incredibly risky. So, very important to not encourage that.
Well, oh, thank you. One of the other things that somebody had mentioned is that women with epilepsy were told by another physician that they shouldn't breastfeed. And so how do you combat that misconception, which I think is still out there?
Yeah, there's such a lag between when we get information and it gets disseminated and what we call implementation science, and it gets also changed in practice. So it's really something that we're constantly trying to get ahead of. So a lot of times there are some books that providers will go and reference, but the books, of course, are always going to be outdated. So what we do is we actually give them a letter for them to take into delivery, to be able to provide to any providers, and anyone who's on call. Are also lactation nurses, as well as the whole staff, that says we have discussed the benefits versus risks of breastfeeding, and we support you if you decide to breastfeed. If any questions, contact us, and then we, once we give the information, then everyone's more comfortable with it. It's really the unknown that I think, a lot of us are uncomfortable with. And so it's, how are they going to know the latest information? They see so many patients with so many different backgrounds and medications are on. So it's just a constant sort of re-education and communication, really, I think is probably what it comes down to.
And so you actually provide your patients with a letter that they take with them?
Oh, right.
Okay. Yes. Well, that's a great tip. What do you think is the best dose of folate to use during pregnancy? I know a lot of times women feel, oh, I'm taking my prenatal vitamin. Is that enough? Or we've been told in the past they should take 5 milligrams or 4 milligrams. What's your current advice?
Well, my advice is not based upon data at all. So
there's your next study, right?
For all of us to feel better, I'm part of a International League Against Epilepsy task force on women with epilepsy, and we actually did a survey and looked at that. So this question is unknown across the world. And what's interesting is, like, Canadian OBGYN will say 5 milligrams, and then others will say 0.4 milligrams. So we really don't know that there's any difference between those amounts. We do know that if the woman starts taking folic acid prior to conception and continues it, actually, then the children also do better in neurodevelopment. And so that's sort of an interesting thought on early benefits. So what I do is I write a prescription for 1 milligram, because I feel like if you write a prescription, it's more solid. You take this prescription with the other one, then get it over the counter, and then they run out if they get it over the counter. And we know that as we increase the number of pills, adherence goes down. So I feel like 1 milligram is a good compromise. And even though prenatal vitamins often have 1 milligram in it, I still continue the one on top of that because it's not uncommon to have side effects from the prenatal vitamins, especially with nausea and constipation. So they might stop that. So that's what I do. But, again, I can't give you any data as to what's better.
Yeah, those are great clinical pearls. Thank you. What is your recommendation for women in the care of the newborn? How do you educate around that?
Yeah, so we talk to them about safety measures, even if they have been seizure-free, it could be a time of increased seizure vulnerability. To be honest, I was somewhat surprised that in the MONEED study, we didn't see increased seizures, even peripartum when we separated it out. So what we defined as delivery until 6 weeks after delivery. And it could be that the women who have seizure worsening during that time, stand out in my mind so much more clearly. That's, the problem with anecdotes. But of course, it makes sense that with the sleep deprivation, some women are going to have seizure worsening or seizure breakthrough. So there's several things. We tell them go back to safety measures. Like during that time, we recommend they don't drive, but again, it's not a legal thing. But also standing water, not to bathe the baby alone without another adult nearby, for them not to get in a tub bath without another adult nearby, or do not lock the door. So we think of those sort of basic safety things again. Of course, then it depends if they are someone who has drug-resistant epilepsy and continue to have seizures, and we take it another step, or if they tend to have myoclonus with their arms, using a sling instead of carrying around the baby. Another big one we talk about is no co-sleeping. So that's also a big recommendation by American Academy of Pediatrics now, but we reinforce it because if a woman were to have a seizure with a baby in bed, it could be serious risk for suffocation. We also, I'm giving you more than you probably want to hear, but we also talk about trying to, even if they are nursing or they're not, trying to at least get some help from a family member so they get one stretch of time that's a little bit longer to get sleep in uninterrupted. So that will often mean at least 1 bottle a day, so that most of our patients do a mixture of breastfeeding and either breast milk or formula by bottle to try to have some balance for their sleep.
Those are great tips. Thanks for providing all of those tips. Now, there's a lot that's been in the media recently about the continued use of valproate in women with epilepsy. And, you showed data about how teratogenic it is, and then the lower IQs associated with it as well. What do you think we need to do to continue to improve, our care so that women of childbearing age don't take this medication without knowing the consequences?
Yeah, I mean, I do feel like we have moved the needle in the US and other sort of similar Western European countries. And we used to, it was only 7 years ago, 5 years ago, we saw a difference between the prescribing pattern for non-epilepsy indications. So we have to keep in mind about 3 times as many women are prescribed as anti-seizure medication during pregnancy for indications other than epilepsy. So for instance, for bipolar disorder, chronic pain, migraine. And so we were seeing a difference, but more recently we're seeing valproate come down across all indications. So recently looked at a study with a school of public health that we're working on, where we did see the valproate prescriptions come down substantially. But it's a real problem in other parts of the world where also there's limited access to other medications from affordability or even just being available. So we're continuing to try to work on that, and the importance of having other options for women of childbearing age. And it's really helpful if you can also think of it as soon as a female reaches adolescence. So rather than waiting until they decide to get pregnant or they have an unplanned pregnancy, to try to look at other options that may provide the same level of seizure control. Of course, we all have some patients who just need valproate. It's the only thing that will control them. But I can say that literally it's been one person that I've been following in the last 5-10 years, and we were able to have her valproate dose very, very, very low with a combination of another medication. So, but others were able to successfully transition to other medicines.
Well, thank you. And thank you for answering all of those questions. I know we have a lot of other questions for you, but let me just end with asking you if there's anything else that you feel you'd like us to help you get the message out in the care of women with epilepsy. What you see is really a need for continued physician clinician education and ways that we need to educate our patients as well.
Yeah, I mean, one thing I still have concern about with those positive findings that we recently were able to report in New England Journal of Medicine is that even that though it was 20 centers, those centers have an interest in this. So, how does that still translate to even the rest of the US for how women are managed during pregnancy? So we see that the types of medications that are being prescribed are improving, but what about a woman who is seizure free? So there's a recent study by the CDC that showed that 1/3 of adults with epilepsy don't even see had not seen a neurologist in the past year, and that's going to tend to be the women whose seizures are easily controlled. And so we're trying to make sure the basic premises are out there across all types of healthcare providers, and of course, women with epilepsy as their own advocate, so that they can make, it's just really important that they get to make their choices based upon informed decision making. The days of sort of telling patients what they should do and not do, thankfully are long past, and we just need to give them the information so they can make their decisions about how they want to proceed with such an important individualized part of their life.
Well, thank you very much, Rich. Really important words to end with.